experiencing very heavy period cramps and symptoms such as not being able to walk or getting very nauseous. And at first I just started to medicate myself with painkillers, just over-the-counter painkillers. And when I went to the doctor to finally search help, they told me that it was normal. And my mom and my sister, they both have period-related diseases such as PCOS and fibroids. So I usually thought it was normal, that I thought everybody was experiencing this much pain. I went to the doctor almost every year to see if I could get a gynecological referral so that they could research what was wrong with me. Every single time I asked for a referral, they would dismiss me and say that it was normal again. And at one point I just stopped caring about my health and thought it was normal, as I mentioned. So when I was 22, I went back to the doctor and they finally did give me a gynecological referral. And out of the test, the result came that I had adenomyosis, which is similar to endometriosis, where the endometrium lining grows outside of your uterus in your muscles. So every single time I explained my symptoms, they would, for example, say that it's normal, or it's impossible that I can't walk, or it's not possible that I have these symptoms. And it made me feel very vulnerable and scared to go to the doctor and tell them my complaints, as they made me feel as if there was something wrong with me complaining about it, or if I didn't have a right to speak about my issues.
Every time I go to the hospital or the GP, I feel very vulnerable and scared to be misunderstood. Throughout my whole life, my mother has always accompanied me to my doctor's appointments. She is a nurse, so it would really help in talking or discussing my symptoms with someone and being heard and understood. Usually we would go to the GP together. I would tell the practitioner my symptoms, and then my mother would verify them out loud. During my teenage years, I never really realized how important it is for me to have someone come to the appointments with me and validating the things I'm experiencing. Furthermore, as a woman with a half German and half Cameroonian background, I never really thought about how much these intersecting parts of my identity influence the treatment I'm receiving from healthcare professionals, especially since the standard subject of study is the normative white male. It has created a fear in my head that what if I have this specific disease or illness, but they just won't find it for me because they don't know how to research on my body. Furthermore, being from Germany, most of my GPs were white, so this made it a little bit worse. I remember going to the gynecologist by myself one time because I was experiencing very heavy period cramps and furthermore knots or cysts along my pelvis that I wasn't really able to identify. When I asked the gynecologist whether she could test me for PCOS, she asked if I'm experiencing general symptoms. And as I told her no, there was no further discussion. I also remember her not asking or suggesting testing for other similar diseases like endometriosis, for example. To this day, I'm still scared that something might not be right with me, but it's very this as one of the many experiences I've had was super disencouraging. So this is why I feel like I am avoiding going to the GP, a fear of being dismissed, not understood, not taken serious.
Me and Serena Williams sadly have something in common, and it is not the love for sports. Both me and her were initially dismissed when we reported our symptoms of a pulmonary embolism. A pulmonary embolism is when a blood clot blocks one of the arteries in your lungs. It is potentially life-threatening. Some people die before they get the diagnosis. It causes shortness of breath. In my case, it also caused a dry cough and chest pain. I got it when I was in the hospital, a place where you're supposed to feel safe, in the vascular surgery department, after a procedure that was performed to address a female-specific condition. And nobody was aware of this type of complication. When I reported my shortness of breath and chest pain 2 hours after the procedure, nobody checked my pulse, nobody checked my saturation, nobody even listened to my chest. Instead, I was told by old white male doctors that the shortness of breath and chest pain were just a result of me being stressed about the procedure. The next day, still experiencing the same symptoms, I started to have self-doubt. I persuaded myself that it was nothing serious, and I was released from the hospital. 3 days later, the symptoms were getting worse, and my partner, who has a medical background, told me that he doesn't want to scare me, but it does sound like a pulmonary embolism. So I went to the ER, and 15 minutes later, I had a CT angio and a diagnosis of a bilateral pulmonary embolism, which means that the arteries were blocked in both of my lungs. And it was the moment when I understood that medical gaslighting is not just something that is painful, is emotionally challenging. It's also something that can actually really lower your chances of survival as a woman, because a pulmonary embolism is a really known complication in surgery, and the symptoms are quite clear. So I should have never been dismissed when I said that.
Having discovered experiences of medical gaslighting and among our group, we have decided to explore this phenomenon. Gaslighting within medical settings reflects deep systemic issues within healthcare, representing a form of epistemic injustice. We delve deeper into the concept of medical gaslighting, examining its manifestations, risks, consequences, and underlying mechanisms. Medical gaslighting refers to a phenomenon in which patients' symptoms, experiences, or concerns are downplayed, dismissed, or invalidated by healthcare providers. It involves the manipulation or distortion of information by medical professionals, leading patients to doubt their own perceptions, experiences, or sanity regarding their health issues. It can delay proper diagnosis and treatment, exacerbate health issues, and cause psychological distress. Additionally, medical gaslighting perpetuates unequal power dynamics within the healthcare system. It can affect anyone who seeks healthcare, but it particularly impacts marginalized groups such as women, people of color, LGBTQ+ individuals, and those with disabilities. These groups often face systemic biases and power imbalances within the healthcare system, making them more vulnerable to having their symptoms, concerns, or experiences dismissed or invalidated by healthcare providers. Jennifer Sebring situates it within the extensive history of physicians invalidating or disregarding the health concerns of marginalized individuals by wrongfully attributing them to psychological causes. This phenomenon can be traced back to the concept of hysteria, a psychiatric diagnosis prevalent in the early 20th century, characterized by the conversion of emotional distress into physical symptoms, which has since been discredited. When viewed through a psychological lens, medical gaslighting positions healthcare professionals as the abusers and their patients as the victims. While medical gaslighting was primarily not an academic concept and got picked up by the academia after patients started using it, it can be seen as a form of epistemic injustice, coined by philosopher Miranda Fricker. Epistemic injustice occurs when harm is inflicted by dismissing someone's capacity as a knower. One of its forms is testimonial injustice, which occurs when a listener, due to prejudice, fails to give proper credit to the speaker's words. A classic example of medical gaslighting is practitioners dismissing women's testimonies about their health, deeming irrational and hysterical. Another form of epistemic injustice is hermeneutical injustice. This occurs when one cannot understand or explain important parts of their experience because there's a lack of shared concepts or language. An example of hermeneutical injustice in the context of endometriosis is when women experiencing severe pelvic pain are not taken seriously by a practitioner. For many years, there has been a lack of understanding and awareness about endometriosis, and women's reports of debilitating symptoms were often dismissed as normal menstrual pain or seen as an exaggeration. This gap in medical knowledge has led to significant delays in diagnosis and treatment. Hence, medical gaslighting is rooted in power structures in medicine exacerbated by issues of age, weight, social class, and race. Thus, to understand the interplay between medical gaslighting and epistemic injustice, an intersectional approach is needed in order to get a thorough understanding of them. Intersectionality is a term coined by Kimberlé Crenshaw. According to her, intersectionality highlights the limitations of considering race and gender as separate, isolated categories of experience and analysis. She argues that Black women experience both racism and sexism in ways that cannot be understood in isolation. Thus, a single-axis framework invalidates their lived experience as the effects of social categories are intertwined. Additionally, intersectional invisibility describes the phenomena of a person with multiple subordinate group identities, like ethnic minority women, not fitting the prototypes of their respective identity groups. Individuals who experience intersectional invisibility often face compounded biases in medical settings. Healthcare providers may lack the training or awareness to recognize the specific needs and symptoms of individuals with intersecting identities. Individuals may be more likely to have their symptoms attributed to psychological factors rather than organic ones, or as they are often underrepresented in medical research and clinical trials, it can lead to a lack of data on how different treatments affect them. Moreover, older adults often experience their symptoms being dismissed as just a part of aging, rather than being investigated for underlying health issues. Similarly, younger individuals might have their symptoms downplayed or attributed to stress or anxiety, leading to insufficient medical attention. People with disabilities frequently encounter healthcare providers who attribute all their medical issues to their disability, ignoring other potential health concerns. Lastly, overweight and obese individuals often face stigma in healthcare settings, where their symptoms are frequently attributed solely to their weight. The focus on weight can prevent doctors from investigating other causes of symptoms, resulting in a lack of comprehensive care and proper diagnosis. To identify the risk factors, forms, and consequences of medical gaslighting, we have reviewed some empirical studies on medical gaslighting, many of them focused on female-specific conditions such as PCOS, breast implant illness, dyspareunia, and endometriosis. Other studies either focused on conditions that affect women significantly more often, such as lupus or long COVID, or narrowed down the study population to female patients. The studies reveal an important risk factor for medical gaslighting: lack of objective physical findings in medical tests. A study on the negative experiences of women with interstitial cystitis revealed that another risk factor for medical gaslighting is the invisibility of a certain condition, for example, pain as well as individualized symptoms. The existing empirical studies on medical gaslighting highlight the urgency of this issue by presenting its possible consequences. A study on lupus revealed that a physician's disbelief in the organic cause of one's complaints results in lower trust in physicians and damages security. The patients also reported increased self-doubt and feeling crazy or lazy. The authors also mentioned medical PTSD stemming largely from accumulation of negative medical experiences. Not knowing the pain's cause is associated with uncertainty, as evidenced by a qualitative study on sexual pain. It also leads women to undermine their bodily self-knowledge. Research on PCOS revealed that women who experience dismissal during the diagnostic process feel defeated, hopeless, and broken. A study on multiple chemical sensitivity, which is a contested illness, listed lack of access to disability benefits and a lack of social recognition as consequences of medical gaslighting. Patients dismissed by healthcare providers also schedule more appointments and spend large sums on more medical tests. Dependent on the system, they may do them out of pocket. Additionally, the studies revealed that among children, symptoms are often attributed to growing pains, hypochondria, and attention-seeking. Some patients, for instance, with interstitial cystitis or chronic overlapping pain conditions, were told by healthcare providers that they were too young to have that illness. Women with PCOS heard from their doctors that they would grow out of it, or that such symptoms were normal for their age. In conclusion, medical gaslighting, especially towards patients with intersecting identities, is a serious and common problem in physician-patient encounters. It should be addressed on multiple levels. Firstly, diversity in medical research is needed to reduce the risk of hermeneutical injustice. Next, medical students should be taught about medical gaslighting and gender bias, as well as varying presentations of certain illnesses and the possibility of an absence of abnormalities in medical tests. Better training on patient-physician communication is also crucial. Thus, addressing medical gaslighting requires efforts including diversifying medical research, educating medical students, and improving patient-physician communication.